Good evening, Your Honor. A 21-year-old male came with complex of pain and difficulty in walking. The left knee for 6 to 7 months. Complex of occasional instability of left knee, no history of trauma, morning stiffness, or other small joint pain. This was the radiograph of APL lateral of the knee joint. What is this? He said that 21-year-old, 21 complex of pain. It's 67 months. Same mistake. Same mistake. It's to it. The preference. Yeah. The radication, the metaphyses, sensitivities, zone of transitions is narrow.
It's narrow. बहुत ऑफिशियल पापा ने पार्टी से वो की है तो
No nitis. So now this is pretty very youth. 21 years.
the face aí what like a face
Sclerosis. It is also a regressive lesion. I would like to say GCT, one possibility. With the upper margin is not seen, it is merging with the rest of the board. I don't have a sclerotic margin here also. So I would say is moderate aggressive or very aggressive.
so permeative I can see take permeative may take type of V-shape here permeation this dots just to build up some aggression it is a lesion
There is no margin.
but of course infection is one different in our bones as well and they really keep tuberculosis as one of my top priorities in this case.
It will lead conditions was. It's a well deep lytic lesion with no sclerosis along the lesion.
For a brutis abscess for a talapanaze,
Which is from meta-epiphyseal. Size also is what epiphyseal per se. This right type of GCB as a first. So differential diagnosis is very good. It was GCT, facial closure receipt, most sclerotic parts is GCT.
Lilith's subcation of the is just media patapase. GCTs generally are equiface and general excipic that are centrally is a common. GCT says
If it does all the crable in that meta-epiphyseal, it's not using lesion, it can go to metaphyses. Here the center of the lesion is metaphyses.
and it is center.
Generally as a so at the same location we see and use one but most commonly see with that so face polish or chondroblastoma opacacy calcification.
Chondroblastoma sclerosis is sort of sclerosis pain on period BSP. And it's very big occasion for a customer. Scooby
Keys there. This CQ was done for the same before this break in the cortex, the south. Tumor is extending into the soft tissue. And you have this articular muscles
I do more efficacious now. No, it will move towards
this is T1, T2 weighted release.
all over GSP. Okay. It's European archer.
On X-ray video,
PDF, we don't see it there. Right?
yep,
Crazy. Don't have a sclerotic pass. Suggest proxamic be sticky. See, you don't have a suggest by CQ also doesn't have
it's no swells. On MRI, it's we let's see that it does not the skewer.
it is suggetory memory, but see, there's any absent or
So most of the time got we see the GCD at hospital what we studied there in the hospital is GCD tend to have the two gray shit or even right like chondroid backways because of the hemocytic depositions.
we got all this sclerotic on MRI. Oh, we cannot focus. Before that,
Yeah. TD. It's also here we can see there is a predisposed.
is it a necrotic? So,
The few cystic component with spastic.
what about the switching? Does look like a necrotic or the solid component.
Which
Because T2, it's T2, left side, huh? Two, a lot of fibers.
Hyperpatched, the fibers of radio. Cystics like Epiphyseal are patched.
So what is suggest? What not in the the suggest more fluid component or just fibers component?
or because in GCT we try to see the trachytex or suburban appearance, which in this is not a straightforward suburban appearance. What we have the tremor, which is still straight there.
No, this one. It's operator. There's a solid pocket. Sorry.
Yes. I mean, so here also you can appreciate the same intensity really as say mass just kanetoshi. So when you are reporting MRI, what importance is we are protected from the joint line till where it is extending. And whether there is a breach, the OD is 6. So GCT, so that be correct in case you have one of. Miss, this is a tech. CZ, sir. That is in Enders, there is also.
Yes, what's that? Yes. Yes. False. Yeah.
Well, the part is that Eddie. It's the most common. The distributed one is the most common here present as paradigm. But the sacrum is the most common the exit. The spike sacrum is the most common site for GC. The signs it's impacts of canes can analyze. So the GCT is because it parts of bikes. So it begins the metaphase and end of the long cone or adjacent to the ossified facial lesion. Usually extends to the end of the long cone, but in the joint surface, leaving the region is about the okay. So this is a pathological state step when negative for Americas. Twin sets us in jade cells. More the jade cells, it is more or less the naive ways. So lesson is the number of jade cells. So there's a dogo is that we see Stromal cells to Giant cells determines the lesion as to be benign or malignant. So many Giant cells we tends to be the benign lesions. There's a more few or no Giant cells that go in favor of malignant species. Yeah. So radiological eccentric epiphyseal subcortical vision expansion cortical. So over pattern the tumor removes the luminous trajectory and prompts reinforcement for remaining tract. So the X-ray makes it. So radiologist alone cannot predict the accuracy of whether the GCT is benign or malignant. So we need a 3 approaches: clinical, histological, and radiology. So concerning feature were put for a malignancy reporting on a MRI or a reporting the tumor is cortex involvement, soft tissue extension, pathological fracture, the ulnar edema, solid mass like enhancement, and associated. So in this, we don't work at loss fracture. This is done.
Which places? Reach it. What will be your MRI report?
Fiery pressure. GCTs. This order. So I have one problem with the religious disease. They pick up pathologist with a weak results without. My humble request is don't use the pathologist diagnosis or radiology. You disturb the radiology and give a differential hypothesis and leave it to the pathologist to confirm that. That is what I personally do. Even the night when I came from data, my boss called me. Okay, in the OT, I went to the OT. Patient was anesthetized on the table and he said, you go wash. Then I said, sir, wait, let me see the X-ray. I saw the X-ray. Then he said, some video, you going to report us, takes it. So he had started, he wanted to correct it. And because I just finished my orthopedic compulsive report, involved me. I said, sorry sir, this doesn't not to unite. I'm about to operate, I don't want to operate. I did biopsy, understand this. Neither do you see. After the abandoned the surgery, 3 years later came as part of support. So many people just go and operate because of the history of surgery. Whether if disasters occurred because the radiologists are doing access. And the end up, it was a malleate, for example. So, or say, for example, you have said this is a JSOT, for example. There are cases which looks exactly like JSOT ended up like this. Suppose they gone and put this, contaminated the entire child. Then what do you do? Kind of similar, this is not weak. Okay, what do you do? Only 10 cases which have had it. So, my humble request to radiologists, you have a pivot status as a analysis or a reward checks. Describe their X-ray. And leave it open second, finally, depression type study. And say, well, I know there's a statement, carry forward with highlight the HP.
That's usually it's like the small scalar. But all the bright full rectangle small plastics and small. Please highlight that peak. And is the coordinate district means they have to do the best for the construction.
But they don't event. Yeah, give us a TC. The display of where we had in the hospital was where we check clinical used to be in the one setup. Pathology is always some other. Like, but Giant Cell Tumor was there for local ictus. Yeah, all chest door, I guess one thing that usually there is something missing here. X-ray doesn't go with the Giant Cell pattern. Usually the Giant Cell pattern will be a reference. It doesn't get through the frames. Yeah, very rare presentation like this. Because Giant Cell, there be purpose. The GTP will get no purpose, and that it won't until late in the disorder. It doesn't with a small tumor. It doesn't get into the soft tissues. So it's an treat so much.
The first text I did so this one, but when I saw this one, no sir. When I saw this on it, I changed my diagnosis because this is almost involving the epiphyses. That's right, epiphyses, right? And this pattern, so the stimming of the cortex, pushing a tumor, is also one of the findings of a Giant Cell tumor.
But an X-ray, would you couple X?
Yeah, yes.
So this is CAS is organized the notch, so it is actually epiphyseal exist, but is the particles. So the notch treats you that bias that it is in the metabasis yes.
But again, I'll tell you again that why that tin pathology comes for blood basis.
The risk factor for local McQuills is surface extension. That's that 2 mm distance from the ocular surface. 3 mm thickness from the affected particle cone around the very gross straight size around 12 staples.